Hi there, my name is Steve Shepherd. I'm a consultant in intensive care and anaesthetics at Bart's Hospital, and I'm here today to talk you through the setup and use of Penlon anaesthetic machines for use as intensive care ventilators. The first thing to say is that they are a little different to the ICU ventilators that you are used to, but actually once you get the basics of how they operate, they can be used quite effectively in a large number of scenarios. So the first thing I'm going to talk through is how to turn it on and do a machine check. This is pretty much all electronic, but it's useful because it means that you're able to set up the ventilator ready to go no matter what your background. Before I do that though, I'm going to talk through some of the most important features of the ventilator and the anaesthetic machine, mainly related to their safety. So if we look at the front of the machine, you'll see that we've got a circuit which is set up with a Bain circuit. This is very similar to the ICU circuits that we've got. We have two filters on the machine, and importantly we have a separate water circuit connected to what is an auxiliary gas flow. The main switch for the machine turning on is here. But there's another switch here which we'd rather you didn't touch, but essentially it diverts gas flow through an alternate route. But this is the main switch on and off the machine. You need to make sure that the machine is connected to power and also connected to oxygen and air outlets of the wall, as with a standard ICU ventilator. So when you turn the machine on, the first thing that you'll see is some information asking you to enter some basic demographics. This is helpful because if you enter the patient's ID, the height and the gender and age, that will help set some of the alarms to appropriate defaults. So we're going to say here that we have a gentleman who's 170 kilos, who's aged 45. Press confirm. And the next thing we'll do is ask you to clear the trend data. We're setting this up as a new patient, so yes, we're going to do that. Now, the first thing you're going to need to do is a system test. So this is done by clicking the button marked System Test here, and you'll see there is an option here for an automatic system test. If you press that, that will firstly tell you through when it was last checked, but also talk through all the steps that you need. At every bedside, you'll find a card which tells you the exact sequence of steps to help support you in doing this check. So, the first thing it says is going to ask you to switch the bag vent switch to vent. I'll show you this. Just here is a switch next to this brown dial. This has an arrow on it which points the direction it needs to be, but essentially there's a picture of a ventilator, and this switch needs to point this way towards the ventilator. Having done that, you need to open the patient's Y piece, so I'm going to take away my patient's lung. And we're going to check that the absorber canister, which is here, is fixed, but also that the ventilator bottle is also fixed and not loose, because both of these are sources of leak. The next thing it's going to ask is that the ventilator is collapsing, which it is. The next few points, numbers 4, 5 and 6, which relate to use of an anaesthetic vaporizer, we're not using, so it can be skipped. And actually the next thing it wants to do is just press start. This next sequence is entirely automatic. It takes about 4 or 5 minutes, and we'll check through the ventilator circuit. It will check that there's gas flow. It will check the oxygen calibration, and lastly check that the mixers are working properly. You don't need to know much more about this, but if there are any problems at this step, please escalate to an anaesthetist or an ODP. Having completed the initial part of the system test and seen that we've got a pass at every point, we're going to continue. The next thing that it's going to want to do is it's going to ask us to occlude the Y piece. So on the side of the machine here is a small area that you can twist and put on. You'll note here that it asks you to press the oxygen flush button. So this is here, and this is used only in the test. It's not to be used at any point when the patient is when the ventilator is connected to a patient. But this essentially lets you fill the ventilator to do the check. You'll see here that the ventilator is filled, and the next thing to do is press start. And now we'll get a test of both the ventilator, but also a test of the circuit to make sure that there's no leak. We're now up to the last part of our check. It says, please disconnect AC supply. So if you go to the wall, pull out the plug, you'll see that the battery is now being highlighted and asks you to reconnect the AC supply, which we've done. And our machine is checked and ready to use. Press finish, press exit, and you'll come back to the standard setting. The next step in setting the machine is to set the default alarms. Now, this is set here using the alarms tab. If you press it, you'll get the machine defaults, which are not suitable for use on intensive care and have to be set manually each time the machine is set up. The recommended defaults are attached to the reading and basic guide, which is next to the machine, but we'll go through each one of those steps. The first one of these is the pressure. So this is the maximum or P high pressure that you set. This defaults to a high of 40, and we're going to recommend as a standard this should be set to 35. This can be changed after a discussion with an intensive care consultant depending upon the patient's physiology, but we'd recommend 35 as a maximum in the vast majority of patients. Next thing is the minute volume. You'll see that this defaults to a high of 8 and a low of 3. This is partially set by the ideal body weight that you've entered when you initially set the patient setup, but these are pretty reasonable, although we'd recommend in the majority of intensive care patients a high of around 12 and a low of around 4, simply because we'll be ventilating at a higher minute volume than many anaesthetics. Next thing we have is the respiratory rate, and you can see here this defaults to a low of 5 and a high of 100. This doesn't really suit our practice, so again, we're going to recommend a low of 10 and a high of 40. As you can see throughout this, the screen is touchscreen, and you use the dial and the knob to press to select your requirement, but the majority of this can be done simply by touching the screen. Next, we have the FiO2. Now, this brings us to one of the most fundamental differences between an anaesthetic machine and an ICU ventilator. In an ICU ventilator, you set the FiO2, or fraction of inspired oxygen, that you want the patient to have. But in an anaesthetic machine, you set a blend of oxygen and usually air in order to generate a gas flow. And the relative proportions that you set give you what your FiO2 is. Now, an anaesthetic machine has this because it's often a more efficient way of using gases if you're using what's called a circle system. We're not using that in intensive care, so essentially we have to blend those gases in order to be sure that we're getting the right FiO2. So just because you dial up a concentration doesn't necessarily mean that's what you're going to get, and hence it's important to keep an eye on what the FiO2 value that's measured within the circuit is in order to be sure of what FiO2 you're administering the patient. The other concern with that is because you're using a blended system of gases, it's possible to give a blend that may give you a hypoxic mixture. And so you can see here the low FiO2 alarm defaults to 20%. Again, that's not really suitable for the majority of our patients, and we're going to recommend a baseline of 40 as a standard. This can be adjusted as patients improve, but will cover a safe margin in the majority of patients. Last thing is the tidal volume, and again, this is set largely by your baseline demographics, and actually they're pretty reasonable. But the last thing is the apnea time, which defaults to 20 seconds. Again, we prefer a shorter value in intensive care, so recommend that this is changed to 10. Having set all our alarms, we can press the cross button, and this will take us back to the main screen where we can set up our modes of ventilation. So we'd like to start and ventilate the patient. So there are two things that we're going to need to think about. Firstly, what mode of ventilation we want to use, and secondly, what gas flow. If we look at the gas flow initially, what we can see here is this dial here tells us what the fresh gas flow through the machine is. And you can see here that if you click on gas mix, you get a choice of what mixture of gases you want. You can either have oxygen and air, oxygen and nitrous, which we have disabled because we're not going to use it in intensive care, or just oxygen. Therefore, you need to pick oxygen and air for all patients. You can administer 100% oxygen using an oxygen air mix, but you can't administer 40% oxygen if you've just chosen air. So pick oxygen and air for all patients. Next thing you want to set is what you want the desired FiO2 to be. Again, you can click on this and you'll notice it gives you some quick pre-selects of 25, 50, 75 and 100. So if I wanted to pick 75, I'd click that. I'd see that it's highlighted and I'd choose it. I can also click that and rotate the button and choose a different FiO2. The last thing to set is the total flow. So the ventilators that we use on intensive care adapt to the patient's minute volume. So if you set a higher respiratory rate and a higher tidal volume, and by that increased minute volume, you'll see that the ventilator will give more gas. Anaesthetic machines don't work like that, and so therefore you have to set what you want the total flow is. This should generally be around the patient's minute volume, but in the initial setup what we recommend is that you pick a default of 10. You can increase this or decrease this depending upon the response of the patient, and it's important that we set the FiCO2 alarm on the capnography on the main monitor. The reason for that is if you find that you picked a value that's less than the patient's minute volume, one of the ways that you'll know that you're not getting good clearance, or what we call rebreathing, is that you will start to increase the inspired CO2 that the patient sees. On the capnograph, you'll see that the line doesn't reach the baseline anymore. Again, there's a diagram and an explanation of this on the patient's, on the bedside card by the machine. But we recommend this is set to a default of a high of 0.5. 10 litres per minute, however, will cover the majority of people for the majority of initial setups, and it can be adjusted later on. So we've set our initial gas setup. The next thing we want to do is we want to set our mode. And if you press mode, you'll see that it has a number of modes which should be pretty familiar to most of us working in intensive care. So volume control, pressure regulated, volume controlled, and then SPONT PSV, which we'd call pressure support. It also has a number of SIMV modes, which I'm going to talk through. But one thing that's most important about these top three, volume control, and pressure regulated volume control, is that they are entirely mandatory. The Maquet ventilators, which you may be familiar with, if a patient tries to breathe over a mandatory breath or tries to breathe in a mandatory mode, the ventilator will sense that, and it will not try and ventilate someone who is trying to trigger. An anaesthetic machine, and these machines are different, and they will continue to ventilate even if a patient is trying to breathe, unless you've put it in a mode like SIMV where you are facilitating that. But these top three modes are entirely mandatory ventilated. So if a patient tries to breathe, what you'll see are signs of the patient fighting the ventilator. So you'll see high peak pressures, you'll see low tidal volumes, and you may see tachycardia or hypotension, depending upon the physiology. But we'll talk through each of those in time. So we've picked volume controlled, which is what the machine defaults to. If you press controls, you'll see what your options are to set on this mode, and I'm going to presume a degree of familiarity with this and say that actually you can set tidal volume, or I to E ratio, frequency or respiratory rate, and then PEEP. It defaults to a PEEP of off, which again you can adjust depending upon what you want. There are a number of other options that we're going to leave as standard, but essentially they don't really help us within intensive care, so we don't recommend that those are changed. Pressure control, you select. Note we've changed the mode and it's given us the control options, but it's also asking us to accept that that's what we want to do. So we can set our P-insp or P-high. P-high, sorry, is P-insp plus PEEP. So this is your P-insp. I to E ratio, frequency, and then slope, which we're going to leave at a default of 0.3. I'm happy with those settings, so I can press accept. PRVC, again, a familiar mode to many of us, and you can set tidal volume, respiratory rate, I to E ratio, and slope. Accept, and then whatever mode that you want to do, you start the ventilator by pressing this button here. So this both starts the ventilator and stops. It takes a little moment for the ventilator to start working. It's slightly longer than the Maquet machines that we may be familiar with. You will see as well that you get a lot of information on the screen, which is very similar to the information that we'd have. You'll have pressure, you'll have flow, and you'll have volume loops. You can see that we are measuring the FiO2 within the inspiratory limb, but also we can see that we're dialing this inspiratory limb gas flow. And again, you can manipulate that by touching. You'll also see the peak pressure, minute volume, tidal volume, and if you click on the other numbers, you may get expiratory minute volume, spontaneous minute volume, or dynamic compliance, all of which can be useful to document on the chart. So we've also see that we've got a blue line before every breath. A blue line means that it's a mandatory breath. You'll see later that you may also see yellow lines, which are triggered or pressure support breaths, or pink lines, which are backup breaths, which I'll talk about in a second. But a blue line is a mandatory breath. I'm going to move now to pressure support. I'm going to pause the ventilator to do this. And you'll see here that you get the option to choose what your backup mode is. So you can see you can have backup volume control or backup pressure control. And again, the numbers in pink are the things that you can manipulate related to that mode. The rest of it is pretty familiar to us, so you can set your pressure support value. Your slope and your e-sense are happy as default, so there's no need to adjust those. But if you see here, we often use a flow trigger on the Maquet machines, and this here defaults to a pressure trigger. You can switch between the two, so if you press and hold, you'll see that you change to flow sense. Press and hold again, you'll see that you change to pressure sense. So I'm going to default this to flow sense, and you can see it defaults to 3. We'll turn down to 2, press OK, and you're ready to go. Again, press accept, and you are back in that mode, ready to start ventilating again. However, this is a good point to say something that I think is quite important, which you can see, having turned the machine off, it's turned our flow back down to a default of 0.2 and 100%. So before you restart ventilation, you need to reselect oxygen and air, and you need to reset your flow. This is important because, as we know, we may want to pause ventilation temporarily, and if you don't do this, what you'll find is that your velos will fall because there isn't enough gas within the circuit. You have to increase the total flow to refill that circuit before you can do that. If you don't, what you'll see is the velos will not reach the top every time, and in doing so, you won't get adequate ventilation. I'll demonstrate that in a moment. You'll see as well, in this patient who's not breathing, the apnea time is set by the alarm. So it's not part of the setup of the mode, but it depends upon what you've set as your apnea time here within the alarm settings before the ventilator will kick in. You will also get an alarm which says apnea, and a comment which says that you're currently in backup mode. The alarm may not sound, but you can clear the alarm by pressing that button here. Looking at the SIMV modes, again, these are pretty similar to SIMV as we would consider it upstairs, but there are a number of small differences that are quite significant. So firstly, if you look at volume control, pressure control or PRVC, if you're just thinking about the SIMV part, it defaults to a respiratory rate of 6, which is too low for the majority of our patients, so we recommend that's turned up to 12. You'll see as well that you set the inspiratory time rather than the IE ratio for the mandatory breaths. That's important because, unlike a Maquet, where if you try and breathe during an inspiration, inspiratory mandatory breath, you can't do that here. You can only breathe in the expired portion. So the machine will give you 12 breaths, whether you're breathing at 20 or whether you're breathing at 6. You will always get 12 mandatory breaths. You can breathe around that, but only when the machine is not giving you a mandatory breath, so in the expiratory portion. That's why you need to set the inspiratory time. We normally recommend somewhere between 1.4 and 1.6. The rest of these values are pretty simple, similar to what we've already set for pressure support, and we can see we can accept that. Coming back to alarms, you'll see that there are auditory alarms which the ventilator will make. They all sound very similar. So this is the alarm for the pressure low, but you get the same tone and same volume for oxygen alarms or for battery failure. If you want to silence the alarm, the button here at the bottom left is the alarm silence. And here you can also see what happens if you have a leak. Your bellows will collapse. When you reconnect or you deal with the leak, the bellows will refill, but it will take time. And you'll see that even at a gas flow of 10, it takes 20 or 30 seconds for that to happen. One way that you can reduce that time is by temporarily increasing the gas flow. The maximum gas flow that you can get through this machine is 20 litres, but you cannot give more than 15 litres of either oxygen or air. So, for example, if you want to give 15 litres per minute of oxygen and 5 litres per minute of air, the maximum FiO2 that you will get will be somewhere in the region of around 75 to 80%. Having increased the gas flow, what you'll see as well is if the minute volume is high and the total flow is low, the bellows will fall, but it will take time for this to fill. As I say, you can increase the total gas flow to fill the circuit again, but this takes 4 or 5 breaths. There is no oxygen boost facility. It's not possible to give a oxygen breath for a minute. The only way you can do so is by increasing the FiO2 that you give the patient. So again, the way you do that is clicking on the inspired oxygen. If the minute volume is higher than 10, you will also need to increase the flow. But you'll have an idea about how well that is by looking at what minute volume you're getting with reference to that, but also if you see signs of rebreathing as discussed on the monitor. For airway interventions like suctioning, the minute volume being around the same as the gas flow should be sufficient for you to fill the circuit. But for interventions where there's going to be repeated suctioning, such as physiotherapy-led airway clearance, it's recommended that you increase the gas flow up to 15 or 20, depending upon what the minute volume is, and then that will give you some space to fill the circuit while that intervention is happening. You can reduce that gas flow back down once the procedure is complete. Number of important points to go through as well. So if you find that the bellows are collapsing with each breath, please increase the fresh gas flow by 10% and call an anaesthetist or intensivist to review. If the FiO2 alarm increases, so that will be on the main monitor, if you find that's more than 0.5 kilopascal, again increase the fresh gas flow by 10% and call an intensive care doctor. All mode change should be made by an anaesthetist. We've shown you how to set some of the parameters, but we're recommending that they are made by one of the doctors as familiarity increases. And finally, unlike the other anaesthetic machines that we're using, these do not need to be recalibrated every shift. Once it's turned on, it can be left on, and you don't need to make any changes to any of the settings or do a repeat use check unless there is a clinical suspicion that the machine is not functioning properly. Again, that's unlikely and should be decided by an intensive care or anaesthetic doctor. That's it. Thank you very much for your time.